we finished up our last lecture video talking about the alveoli, which are the structures within the lungs where gas exchange takes place. So if we look at, I'm going to make this a little bit bigger here if I can. Maybe not. Get rid of this. There we go. Okay, so we look at the lungs. They're these air sacs, and they're surrounded by blood vessels, and these are capillaries which eventually will lead to the pulmonary vein. Remember, the veins carry blood to the heart, so because this just picked up fresh oxygen from the lungs, the pulmonary vein carries oxygenated blood. That's why it's usually given a red color in diagrams or models. The pulmonary artery carries blood away from the heart, so that's carrying it away from the heart to the lungs to pick up oxygen. So that's why the pulmonary artery is blue. So these are the only vessels in the adult body that are opposite in terms of oxygenation when we talk about arteries and veins. Veins usually contain low oxygen blood, arteries usually contain high oxygen blood, but in this case, because the blood has not been to the lungs yet, it's reversed. The pulmonary artery has low oxygen blood, pulmonary vein has high oxygen blood. So these are actually smaller vessels that will lead to the pulmonary artery and vein. So that's why that's shown out here, because the first branch off of a capillary bed is called a venule, and leading to a capillary bed is called an arteriole. So looking at the lungs then, we talked about how they're made up of these bronchi that branch into secondary and tertiary bronchi and eventually becoming bronchioles, and then finally the alveoli. So the lungs are surrounded by a membrane called the pleura. So if I look at this picture here, there's a membrane around the lungs and it's called the pleura. So what happens is when the lungs inflate and get larger, that space there's fluid in that membrane called pleural fluid, the space gets smaller, and then as we inhale, as the lungs move outward, that stretches that space a little bit, and then the space in there gets bigger. So as the lungs move out, as the rib cage moves out, that space in the pleural fluid gets a little larger. And then as we exhale, then that space decreases again as the rib cage and the lungs come in closer contact with one another. But it's really important to have that membrane around the lungs, and it's filled with a fluid called pleural fluid, and that's what keeps the lungs attached to the body wall. If someone should have a punctured lung or a surgery that punctures that membrane around the lungs, that would cause the lungs to collapse because they no longer stick to the chest wall. So that pleural membrane with that fluid inside is really important for keeping the lungs inflated and keeping them connected with the body wall. So looking at the pleural fluid, we said it has a surface tension is what we call that, and that's just stickiness between water molecules, and that's what keeps the lungs moving outward. Like I said, when the thoracic cavity enlarges with inhalation, that pleura pulls outward and keeps the lungs attached to the body wall. There's two layers of the pleura. There's the parietal pleura that attaches to the body wall, and the visceral pleura that attaches to the lung. So it's a double layered membrane essentially, with a space in between, again, that helps keep that lung inflated and moving with the body wall. And sometimes those lungs or those membranes can get inflamed if someone has a chronic respiratory infection that just doesn't want to give up. Sometimes that can lead to pleurisy, and it's very painful to take a deep breath for people that have that inflammation of those membranes around the lungs. So we call that pleurisy. So let's talk again about the alveoli. This is where all gas exchange is occurring. So every time someone takes a deep breath, they're inflating these alveoli, and the gas, the oxygen diffuses from the alveoli into those capillaries and into the blood. And the carbon dioxide leaves the capillaries, enters the alveoli, and is exhaled with every breath. So we have about 300 alveoli in our lungs. And the type of tissue that makes up the alveoli is simple squamous epithelium. This is the thinnest of the body tissues, and that allows for quick gas exchange. You wouldn't want to have thick cells for these oxygen and carbon dioxide molecules to cross, so having a very thin membrane with a large surface area is important for gas exchange. And And that's the function of the alveoli, is gas exchange. So they're made up of the simple squamous epithelial cells. So oxygen is going to diffuse from the alveoli to the blood, and carbon dioxide goes from the blood to the alveoli because that's a waste gas. And the alveoli are lined with a special substance called surfactant, which keeps the alveoli open because there's water that lines the alveoli, and these really delicate tiny little alveoli would collapse and form a water droplet from those water molecules if we didn't have surfactant. So surfactant helps keep the alveoli open and prevents those water molecules from closing them and forming a water droplet inside the alveoli. And babies, when they're born, they don't make enough surfactant, so they have a little more difficulty with breathing, and premature infants need a lot of respiratory support because they don't have that surfactant production complete yet. And they're at risk for lifelong respiratory issues if we can't ventilate them appropriately without damaging the lungs. So looking at the process of breathing then, the diaphragm is the major player, as well as the external intercostal muscles here that we can see that lies between the ribs. So what happens is the nerves coming from the brain, from the brain stem, the medulla oblongata, stimulate the diaphragm and the external intercostals to contract. When the diaphragm contracts, it moves down. And when it moves down, it increases the volume inside the chest cavity, and that drops the pressure in the chest cavity, and then air comes rushing in from the outside from high pressure to low pressure. So inhalation is an active process that requires contraction of the diaphragm in the external intercostals to make that volume change, to make the inside volume of the thoracic cavity larger so air can come rushing in naturally. So we don't suck air in. Air flows in naturally due to an increased volume and a decreased pressure inside the chest cavity and the lungs. So then at the end of inhalation, as the pressures become equal inside the lungs and outside the lungs, then that nerve impulse to the diaphragm and external intercostals stops, and the diaphragm moves upward again. The external intercostals bring the rib cage down and in, and then that decreases the volume of the chest cavity, which increases the pressure inside the lungs, and then that will force air out from higher pressure in the lungs to lower pressure outside the lungs. So when you look at the action of breathing, it requires the muscles to contract first, change the volume, which changes the pressure, and air flows from high to low pressure in or out of the lungs, depending on which phase of breathing we're in. So it's important to understand that these muscles and the rib cage must be flexible. So the muscles have to respond to the nervous input, and the rib cage needs to be flexible to expand and contract the sides of the thoracic cavity for those lungs, again, to increase in size and decrease in size. So people that have stiff lungs or ossified lungs, like older people, the elderly, they have less functional cartilage here on either side of the sternum, and those ribs aren't very flexible, so they have a hard time taking a deep breath or coughing hard because they can't move those ribs very easily because they're stiff with age. Or anybody who has a neuromuscular disorder is eventually going to have trouble with breathing because those muscles aren't contracting and expanding the size of the lung and the rib cage. And there's an animation on Blackboard in our folder that shows you the process of breathing and puts this all in motion. I highly recommend you watch that animation to really understand the steps involved with airflow. So again, we need that surfactant to keep the alveoli open and not forming a water droplet. And then as the lungs are able to decrease after a big inhale, the ability of the lungs to decrease in size is called recoil. So it's important that we have this constant movement of the lung and the thoracic cavity outward and inward for the movement of air. But again, if we have a punctured lung, that's when air enters that pleural space, and that causes the lungs to not be connected to the chest wall anymore, and they collapse inward. So it's important that that pleural membrane be kept intact. So surgery can interfere with that. Gunshot wounds, stab wounds, broken ribs in an accident can puncture the lung and cause the lungs to collapse. So lots of reasons that that membrane can be penetrated and causing collapsed lungs. So sometimes when we need to take a large inhale, like when someone is gonna maybe, yawn and they're taking that large inhale, that allows extra muscles to be involved. So we use muscles of the back, chest, and neck when we're taking a really deep breath. So it's not just the diaphragm and external intercostals that are involved when we breathe beyond a normal resting inhale. The same thing with expiration. When we want to exhale really hard, like if you've been out with friends and laughed a lot or had a bad respiratory virus and spent the whole night coughing, you'll notice that your abdominal muscles get sore. That's because to increase our expiration, to get a good breath out, we use our abdominal muscles to compress the cavity and force, that push upward up against the diaphragm and force that air out. So we have extra muscles to help with excess breathing in or out. So sometimes when we're looking at people with respiratory disorders, we can use a spirometry to kind of measure the movement of air in and out of the lungs. So this spirogram here just shows the small amount of air that moves in and out. So this would be inhalation, exhalation, inhalation, exhalation. And it's about 500 mils of air. If you look at the difference, 2400 to 2900, that's a difference of 500. So 500 mils of air moves in and out with every breath. But once we exhale gently and take a big deep breath inward, we can see there's a lot more room for us to bring air in. That's called our inspiratory reserve volume. That's the extra volume in those alveoli that can hold air if we need it, like I said, just prior to a yawn, or someone who's smoking on a cigarette. They're using that inspiratory reserve volume. And after we've given a normal exhale, we have extra air that we can blow out as well, and that's our expiratory reserve volume. So for example, when you sneeze or cough or laugh really hard, you're using that expiratory reserve volume. But there's always this residual volume that we can't exhale, and that's the air that stays in the airways and the alveoli to keep the alveoli open. Because if we blew all the air out of our lungs, our alveoli would collapse and become sticky, and that would be very dangerous, and we would not have gas exchange. So this residual volume is part of that is used for constant gas exchange, because those alveoli are always going to stay open. So if we add up all the volumes, this is called tidal volume, just the amount of air moving in and out of the lungs. If we add that to my maximum, my inspiratory reserve volume and my expiratory reserve volume and my residual volume, that's the total lung capacity. But again, we can't really exchange the residual volume voluntarily, so the vital capacity is talking about the amount of exchangeable air. This is the air we have control over, that we can blow in or out depending on what we're doing. So that's what we call vital capacity. So some of the next couple of slides talk about the different conditions within the respiratory system. So I'll just let you review those those on your own. But I want to talk a little bit about nervous control of breathing. So if we look at this diagram here, we can see that we look at the lungs are highly innervated, the muscles over the lungs are innervated. I shouldn't say the lungs are innervated, the membranes around the lungs are innervated. So damage to the lungs or surgery on the lungs is very painful. So people that have lung surgery need lots of pain relief, because it's a painful surgery to go into that chest cavity. So lots of sensory receptors are on the outside of those lungs. But we can see that the base of the brain, the medulla oblongata, is the respiratory center, and that's what controls the rate of breathing. So we don't have to think about it, it just happens on its own. And those external intercostal muscles expand the ribs when they contract. And again, the diaphragm flattens and moves down when it contracts, and that is all going to increase the size of the chest cavity and allow inhalation to occur. The name of the nerve that we find on the diaphragm is the phrenic nerve. So it's called the phrenic nerves on either side of the spinal cord that synapse or that connect to the diaphragm and allow it to contract. And then the intercostal nerves are the ones that stimulate the external intercostal muscles to contract. So together those nerves come off the brainstem and regulate that breathing. And only inhalation is the active part of breathing that requires nervous input. The exhalation port is just when those nerves stop their input and the muscles relax, and then the thoracic cavity decreases and air goes out of the lungs. So when we look at what controls breathing in terms of other factors outside of the nerves, we know that the body is very sensitive to rising carbon dioxide levels, because we know that carbon dioxide is a waste gas and it's a result of metabolism. So if your metabolism is working hard, for example, if you're exercising or you have a fever or high body temperature because of activity, that's going to cause increased carbon dioxide in your blood, and that's going to stimulate the respiratory center, that part of the brain, to increase your breathing rate. So anytime you increase carbon dioxide in the body, that's going to increase the respiratory rate. So if you hold your breath, carbon dioxide is going to build up from your tissues, releasing it as a waste gas, and eventually you're going to need to breathe, and that stimulates the body to breathe. So carbon dioxide is the number one factor. Increasing carbon dioxide levels is the number one factor that stimulates breathing. One would think that it would be dropping oxygen levels, but actually carbon dioxide is the primary reason for breathing, and oxygen levels would be second. So rising carbon dioxide is the number one stimulus that increases breathing. So the rest of these are just infections and conditions related to the respiratory tract. I'm going to let you read over those on your own, and that also is part of your discussion board this week. So that concludes our lecture on the respiratory system.